tumor, a teratoma, which produces thyroid hormone. So there is thyroid tissue located in the ovaries. And then you can have metastatic thyroid carcinoma, metastasized all over the body. So thyroid tissue is multiplied several folds, and then all of them produce small amounts of thyroid hormone, and together they lead to a thyrotoxic state. So if you have this condition, and once we have excluded that it's not because of biotin or some assay interference, one way of looking at it, trying to differentiate whether it is on the left side where the gland itself is overactive, and these are the conditions where most of the time we need an active treatment. On the left side, if it's thyroiditis, we generally wait and watch and allow the thing to pass its normal course. Sometimes if it's a painful thyroiditis, we need to use steroids or anti-inflammatory agents for symptomatic relief. And then on the left, Graves' disease, then toxic multinodular goiter, toxic adenoma, and then there could be certain conditions related to pregnancy where HCG is secreted by the placenta, which acts like TSH and therefore can stimulate the thyroid. So there could be some conditions which will deserve its own attention. So one way to distinguish between, let's say, the most common cause are the ones which are marked in bold. To distinguish between Graves' disease, by far the most common cause that we see, and thyroiditis, one way would be to look at an isotope uptake scan. Radioactive iodine uptake is the classical scan that is done. So if it's overactive thyroid, meaning here I use the term hyperthyroidism, where the thyroid itself is active, the uptake is high, or it could also be normal. On the other hand, if it's a thyroiditis, the uptake is low or absent. So all cases of thyrotoxicosis do not have hyperthyroidism, but of course all cases of hyperthyroidism are also thyrotoxic. And so this is once again a technetium. So radioactive iodine scan takes 3 days, you have to wait 48 hours, administer. So these days people are in rapid flux, so they may not want to wait for so long. So technetium scan is easier, but you have to administer the dye intravenously. You get a scan in 6 minutes. And there also you see increased uptake over the thyroid, suggesting an overactive thyroid. That apart, now we must admit that availability of isotopic scans are not wide. Within the precincts of Kolkata, yes, we do have a few centers, but still not enough centers. And outside of Kolkata, practically none is there at this point of time. So another way of looking at or trying to differentiate between Graves' disease and thyroiditis would be to do an ultrasound scan, which is more easily available, and which will show increased vascularity of the glands, which will suggest that it's an overactive thyroid. And this is the other side of the picture, thyroiditis. On the left side, there is no uptake compared to the previous picture where there was dense black spots on the thyroid. Here we do not have any uptake there. Rather, these are the salivary glands, which are not supposed to take up. They take up iron to very little extent. Here they are the prominent ones. The thyroid bed is clear. And then you can also show decreased vascular flow. This is not a Doppler study though here. Right, so in order to differentiate between the two, and therefore to decide whether we have to start on long-term treatment or antithyroid treatment or some form, one way of trying to differentiate is to look at thyroid, the TSH receptor antibody, TRAB, which, because Graves' disease is an autoimmune condition caused by this TRAB, it will be positive in Graves' disease, it will not be positive in thyroiditis. However, this is also a costly test and not available in all the labs. So the question really arises that for most of the physicians, do we always need to rely on a scan, isotopic scan, or a thyroid antibody test to distinguish between the two? The answer would be these are preferable, but my take is if the patient is symptomatic of thyrotoxicosis, at least over 3 months, probably even better over 6 months, you may take it that this is an overactive thyroid itself. Thyroiditis features do not persist for so long. So symptomatic over 3 months or 6 months, this is overactive thyroid. Beyond that, there are some biochemical jugglery that you can do, T3 to T4 ratio. The higher the ratio, more likely that the thyroid is actively producing more hormone rather than passively leaking out hormone. And then also the vascularity of the gland can be a criterion. So this is what, and I deliberately have kept my slides very few about management of the most common condition of hyperthyroidism, Graves' disease, which is an autoimmune condition which again has its natural course. The active course may be for variable number of years. It may also on its own run out its course, but that may take several years. So the options of treatment are 3. One is the use of antithyroid drugs, the use of radioactive iodine, and the third is surgery. There are personal preferences for different physicians, but I think we need to discuss with the patient and decide which is the best, and discussing the pros and cons of each treatment. If you talk of antithyroid drugs, the pros is, of course, you take some tablets daily, and the cons are that the treatment quite often needs to be prolonged. Now, how long can you take antithyroid drugs? Here again, there would be differences in opinion. What would Professor Endiab Majumdar think? How long could the patient be on antithyroid drug?
We usually give 1.5 years period. After
Right.
that, nowadays, the guidelines suggest to prevent the recurrence, we can give small dose for indefinite period of time.
Right. So your preference is for 1 to 1.5 years. Dimmallo?
Sir, in a lot of patients I go up to 5 years because that is what the data is. But generally, would still prefer most for 1 to 1.5. Those who don't want to go for radioiodine therapy, there generally we have to go for longer periods of time.
Right.
I give the option after 1 to 1.5 years.
Right. So those are the options. I quite often allow my patients to continue antithyroid drugs indefinitely. Actually, I have patients on it for 10 years also. But general recommendations are exactly what Dr. Majumdar and Dr. Sannal has suggested. My grouse is when you treat with something else, radioactive iodine or surgery, you are transforming one disease to another. The hyperthyroid, yes, that's more difficult to manage, but you are not making the patient normal, healthy. You're making him or her hypothyroid. So that has also got to be part of the discussion with the patient in those whom we are going to administer radioactive iodine. Because these days the dose of radioactive iodine, I do remember Dimmallo Shanna's paper that even small doses of radioactive iodine, 5 millicuries, was effective in a fair number of patients. Was it 60%, 70%? Yes. But these days the tendency is that you knock it out straight away, give a large dose, so make the patient hypothyroid and start on replacement treatment. So that's something that we need to discuss. And with antithyroid drugs, of course, there is a small baggage of adverse effects related to mainly the two most dreaded ones are agranulocytosis, the other is hepatotoxicity. None of which is common, not more than 1 in 1,000, but still we need to make our patients aware when we are starting on them, how to be on the look for it, what to do if there are any suspicion. Radioactive iodine, again, possibly the efficacy is better if you give it de novo, straight away, without the patient being exposed to antithyroid drugs. That can apply if the patient is relatively young and the symptoms are not marked, the T3, T4 levels are not very high. In those instances, you can straight away, if we have decided that radioactive iodine therapy is the way to go, then you can straight away administer radioactive iodine. If the patient is elderly, if you use radioactive iodine, especially in those who are significantly symptomatic, there is risk, because there is an initial risk of the thyroid itself, as it is being damaged by the radioactive iodine, leaking out hormones into the bloodstream. So the high levels of hormones could lead to atrial fibrillation and other cardiac complications, especially in the elderly. The risk is much less in the younger generation. Surgery, of course, most people, if you talk about surgery, they won't accept first time, but some patients actually do suggest or ask if we could go for surgery. Those are small numbers. From my side, if the gland is very big, then our recommendation will be for surgery. The patient may not agree, and then we may need to go to the next option. And the other is, if there is a nodule in Graves' disease, typically it's a diffusely enlarged thyroid gland, but there could be some nodules in such a situation also. If that is suspicious, then possibly our bias is more towards surgery, so that you get the gland out, you get a histopathology and know exactly what is lurking there. There could be instances of papillary carcinoma of thyroid or whatever in a patient with Graves' disease. So once you decide on medication, which medication, there are 3 to choose from: carbimazole, methimazole, propyl thiouracil. The last is not widely available, but it's there as an option. It has a relatively shorter duration of action, needs to be given multiple times in a day. Carbimazole is a derivative of methimazole, is a metabolite of methimazole in the body. So theoretically, methimazole may be, methimazole is what carbimazole is converted to, and is the active form in the body. So theoretically, it sounds that methimazole should be better, that you use the drug that is actually active in the body. But if you look at various data, there is not much of difference in terms of the efficacy of the two agents. The dose requirement for methimazole is somewhat lower compared to carbimazole. Before we start treatment of antithyroid drugs, do we need to do anything else apart from the T3, T4, TSH and whatever the thyroid antibody or scan or whatever? I feel that we should have a baseline complete blood count, possibly also liver function test, because you can have subsequent changes in the blood counts, and then you know what was the baseline. And as I suggested, that agranulocytosis, hepatotoxicity are issues that can be that can happen uncommonly, but we should counsel our patients. And we have already discussed about how long. Now, about the dose of radioactive iodine, I think we have already discussed. Maybe today we are looking at least at 10 millicurie for most. Partly is related to the size of the gland also. 10 to 15 millicurie is a dose that is mostly suggested. And then in terms of surgery, again, it has seen a change from the years that I was a student, whether undergraduate, graduate, or even during my DM training days, subtotal thyroidectomy was the norm. You do not remove the entire thyroid, so you don't make the patient hypothyroid. But then it was found that many of those patients in whom a little bit of the thyroid is left behind, the relapse rate is higher. So if you are trying to treat the disease, actually you should remove as much of the thyroid as possible. So near total thyroidectomy is today what is suggested, but which also will mean that most patients will land into hypothyroidism and will need replacement treatment. So with this, I would like to sort of sum up. So I think clinical history and examination are must, non-negotiable. Just looking at the blood reports and advising a drug is not correct in any branch of medicine, including this condition. And drug history, what I meant here is not only history of thyroxine, but also other drugs, supplements, hair supplements especially, because they may be playing up with the hormone assay reports. And once again, even if you made a diagnosis of thyrotoxicosis, this is not the same as advising an anti-thyroid drug straight away, methimazole or carbimazole. We need to evaluate and then decide. And then, of course, treatment needs to be a shared decision making. Thank you very much. If we have any time for discussion, I'll be happy to.
Thank you, sir, for your illuminative discussion. It's always a privilege to listen to you, sir. So can you please sit? We have extra 2 minutes time because we have finished 2 minutes earlier. So I think audience, Dr. Supratik has a question.
Yeah, can I share something? Because on the last few occasions that I have spoken at different times, at different places, because these days I no longer time my talk, and I found that I'm overstepping the time limit, which has been discourteous to the organizers, to the conference. So this time I have, thanks that I have been able to stick within the time limit. Thank you very much.
Thank you, sir. Please be seated with us. I think Dr. Supratik Bhattacharya will ask.
I just wanted to ask your opinion regarding whether you reassess the TRAB at the end of 18 months and see if the TRAB has come down, which means if you stop, the chance of relapse is theoretically less. So how often do you do that? And secondly, I think, did I not see or did we miss out the central causes of hyperthyroidism? The TSH
Which one, sorry? What was the second part? Let me take the first part.
TSH, OMA, and thyroid receptor
Yes.
resistance. Did we talk about that?
We talked about TSH woman.
We did.
Yeah.
Oh.
Right. So that's a very pertinent question about TRAB. Now, at least my experience has been I always try to look at TRAB before stopping antithyroid medication. My experience is patients, despite getting negative TRAB results, have relapsed. So that is not definite sort of guarantee that this patient will not relapse. Probably, I think almost equally important is looking at the thyroid gland itself. If it's almost sort of become impalpable, that probably will count equally as TRAB measurement as a predictor of relapse or remission. So yes, I do, but that does not guarantee.
Sir, can I ask a question? It's a practical problem, my patient. So young lady doctor, 29-year-old, she was treated for Graves' disease earlier during her post-graduation period. That was in AIIMS Bhopal. And then she joined in service in railways where I am. So she now wants to have a pregnancy, desirous for pregnancy, married for say 2 years. So at this time, the patients, she repeated the thyroid function test. Thyroid function test is absolutely normal, but the TRAB is high. It's too high. The upper limit is at least I will say 3 times or 2.5 times above the upper limit. And when the drug was stopped, at that time, her TRAB was negative. After that also, with curiosity, she has done a TRAB that was also slightly raised at that time. And nowadays, now when she is planning for pregnancy, her TRAB is too high. So what will be the strategy in this case? Because thyroid function test is absolutely normal.
I think she should be allowed to plan for pregnancy, but we need to follow up closely. And here with the positive, strongly positive TRAB, the possibility of the TRAB transferring to the fetus
so
causing...
I have also counseled in that manner that neonatal thyrotoxicosis, the obstetrician and endocrinologist should be more cautious. But at this time, is there any, should I tell the patient to, or the lady to repeat it after 3 months and then I think so. It will not differ much.
No.
Okay. Thank you, sir.
Sir, I have one question.
And provided your lady was not on biotin in large amounts,
sir,
then
I have
maybe
one
you will
practical
repeat.
question, sir. Sir, one practical question. So, how is the maximum dose of carbimazole used, maximum dose
Yeah,
that can be used maximally?
I tend to believe that there isn't a concept of carbimazole resistance or something like that. So we have used up to maybe 60 milligrams in a day, not gone beyond that, but most of the time I think 15, 20, 30 milligram is enough. Most of the time. We have to, once again, like Rana mentioned about compliance, we have to look at compliance also if we are not getting the correct results. And then, of course, the other thing is, sorry, which I did not include, is after starting antithyroid drug treatment, how often do you test and what do you test? So everyone will come up with, after 6 weeks, 8 weeks, the TSH is still 0.01. And the patient is very disheartened that you started treatment, but TSH is still low. So this is also something that we need to counsel, and I, at least to avoid this complication, I tell them to check only T3 free T4 after 6 weeks and go on doing that till the T3 free T4 is well within the normal limits. I do not ask for TSH, but of course there are helpful labs who do all the 15 tests and the patient comes with the low TSH.
They don't show the prescriptions also, sir. They say ki amar thyroid report ta kore din. Naturally, all the 3 reports come.
Patients are more worried about TSH. So thank you, sir, for your
Thank you very much. Thank you.
presentation. So I call.
After that, after the clinical lectures, may I call upon Dr. Shumita Kundu, the well-known radiologist, who will be talking on thyroid images, which is almost integral part of the thyroidology, and she is a very eminent radiologist and very good orator. We have also learnt a lot in our student days from her, and I think Professor Chaudhuri has already shown some of the images in his lecture. So, Dr. Kundu, please.
Well, good evening, everyone. Eta?
Right.
Okay. Can you hear me? Good evening, everyone, and it's indeed a pleasure to be here today to participate in this scientific program, and I thank the organizers for their kind invitation to speak on imaging of thyroid gland. There are various modalities, as we all know. Primarily, the most common one is ultrasonography, which can sometimes be topped up with Doppler and occasionally with ultrasonographic elastography. Then most important is isotope studies. Contrast enhanced CT and MRI can be helpful in certain scenarios, though they are not the primary investigation of choice. Imaging guided biopsies are used, and usually it is ultrasound guided biopsy which is done for evaluation of thyroid nodules. If a thyroid nodule is suspected, the first imaging modality is preferably ultrasonography. The next investigation is radioisotope studies with 99 technetium pertechnetate, iodine 131 or 123. CT and MRI are required for assessment of loco-regional extent of disease and for evaluation of metastasis. CT is better for evaluation of calcification and tracheal invasion of lesions, and MRI is helpful for better soft tissue detail, and if iodinated contrast is to be avoided, which would be needed in a CE-CT, and also in young individuals and children whom we do not want to subject to ionizing radiation, MRI would be a helpful modality. So, this is the image of a normal thyroid gland in the axial plane or transverse plane, where we can see the right lobe, the isthmus and the left lobe, the trachea in the middle, the marked in green is the esophagus, and you have the carotid arteries on either side. Whenever we do an ultrasound of the thyroid, particularly in cases of nodules, we are supposed to follow certain guidelines. There are various guidelines, of which the most commonly followed is the ACR TIRADS guideline. TIRADS means Thyroid Imaging Reporting and Data System. Just as you have PIRADS for prostate, BIRADS for breast, LIRADS for liver, so TIRADS for the thyroid. What these classifications do is give us a direction to see what is the composition of the nodule, what is the echogenicity of the nodule, what is its shape, its margins, and if there are any echogenic foci within it. Depending on these criteria, there are certain points as I have marked in the slide. If it is a total cystic lesion on ultrasound, that is, it is totally anechoic, then it is given 0 points. Similarly, as the composition of the nodule changes, the points increase to the solid lesion or a nearly solid lesion being 2 points. Similarly, for echogenicity, whether it is anechoic, hyperechoic, hypoechoic, depending on that, the points will increase or decrease. The shape. In the transverse scan, if the nodule is wider than tall, then it is 0 points. That means it is more likely to be benign. If it is taller than wide, then it gets 3 points. That indicates that it is more likely to be a malignant lesion. So, we calculate all these points, sum them up and come to a TIRADS score. Out of these, if it is a 0-point score, then we know it is a benign lesion, so FNAC need not be done. If it is 2 points, we are still not suspicious, so patient can be followed up and patient does not have to undergo an FNAC. If it is TIRADS 3, we are mildly suspicious. If the lesion size is more than or equal to 2.5, proceed for an FNAC. If it is between 2 and 2.5 and 1.5 or below, then we know we can just follow up the patient. If it is having TIRADS 4 category, then it is moderately suspicious and we have to proceed for FNAC more frequently. And when it is TIRADS 5, we know that this is most likely to be malignant, so we go ahead with the FNAC. Then we also have TIRADS 6, which is the category where we know that this is a thyroid malignancy. Now, this is an example of a thyroid nodule which is totally anechoic. So, this is a cyst and this is having a TIRADS category 1. So, this is benign, unlikely to be malignant. So, this is a benign nodule and this is a nodule which is suspicious. Why? Because it is hypoechoic and it also has multiple hyperechoic foci, punctate foci within it. This is a very conservative estimate in one of the studies which indicates how much percentage of patients will have a malignant nodule, but there are other studies which have said a TIRADS 5 lesion would go up to 86% chance of having a malignant lesion. Let us see some more examples. This is a nodule which is having little, it is almost isoechoic to the thyroid, little hypo than that, and it also has certain small cystic foci within it. It is solid with tiny cystic foci and this is known as a well defined spongiform appearance and this is TIRADS 2. So, we do not consider it to be likely to be a malignant lesion. This lesion is having isoechoic appearance compared to the normal thyroid gland and this is has a very well defined outline. So, we put it in TIRADS 3 and we think that this is also unlikely to be malignant. But these two lesions are a different, have a different appearance. Fairly marked hypoechoic lesion is here and one which is very inhomogeneous in echogenicity, multiple microcalcifications, punctate hyperechoic foci likely to be a TIRADS 5 lesion and we would straight away proceed for a biopsy to rule out malignancy. along with the thyroid normal scan, we can also do thyroid elastography, which estimates the elasticity of the nodule.